Hello, everyone. I'm Sherry with the CGH Health Foundation. Welcome to our Growing Healthier program. This educational series is sponsored by the CGH Health Foundation. And every month we try to educate you about important health topics and also get an opportunity to introduce you to some of our very knowledgeable health professionals. And our programs are hosted by Dr. Bill Bird, our Chief Medical Officer. In today's program, Dr. Bird is going to be talking about diabetes management technology with our guest, Dr. Angel Blasquez. And Dr. Blasquez has been on our program many times. We always enjoy talking to him. He's a family medicine practitioner in our downtown clinic, and he knows an awful lot about diabetes. And he's going to be talking about the various technologies, some of the newer ones that can help to manage your diabetes, things like phone apps and insulin pumps, etc. We do not have a Growing Healthier program scheduled for December. We don't usually have one then. In January, our program is going to feature Dr. Marcia Jones and Dr. Nancy Tran, and that is going to be about our new menopause clinic. And we don't have a date nailed down, but if you will look for your Healthlines newsletter in the mail around the first of the year, or keep track of our Facebook page, you will find the date there as soon as we have that scheduled. At the CGH Health Foundation, we've been working really hard on developing programs and services for our patients who are suffering with dementia and for their caregivers as well. And so I have a couple of programs that I would like to tell you about that are coming up. On Tuesday, December 10th at 9:30, we're going to have a coffee for caregivers, primarily talking about the holidays and dementia. And the presenter there is Aileen Zay from the Illinois chapter of the Alzheimer's Association. And if you want to attend that program, just give our dementia care navigator, Beth Sturck, a call. Her phone number is 815-625-0400, and her extension is 3977. And also, the Health Foundation hosts the WITS fitness, brain fitness classes. They're the second Tuesday of the month at our office at 2600 North Locust. And the WITS is a brain exercise class, and the presenter is Kara Schweitzer from the Illinois University of Extension office. And again, for those, if you would like to participate, they're not limited to just, I said dementia caregivers, but really anybody can participate in the WITS brain exercise class. And you can register for that class by calling Beth also. Okay, Dr. Bird is out there ready and waiting to talk to Dr. Blasquez, so I will turn the program over to him.
Thank you, Sherry. Appreciate the intro. Maybe marketing staff, if you could put Beth Sturck's phone number and extension up just for a moment while I'm talking, just so folks have that if they're interested in those offerings that Sherry just talked about. Well, I am looking forward to our conversation today with Dr. Angel Blasquez, and in particular, some of the new things that are happening in diabetes technology. So kind of a targeted conversation, but I think you'll find it very interesting in terms of how the world is changing for folks who have a diabetes diagnosis and who need insulin. So without further ado, let's get Dr. Blasquez here with me. Hey, hi, Dr. Blasquez.
Hi.
Doctor, by the way, for folks who don't know, Dr. Blasquez is a family practice doc. His office is down in the downtown professional building in Sterling. And he, for years, he has been our diabetes guru here at CGH. And he oversees our diabetes center that we have in that office space. So he's someone that knows what's going on here as far as diabetes and diabetes care. So Dr. Blasquez, questions?
No, thank you for having me.
Yeah.
Nice to hear.
So ready for a few questions here? Can you hear me?
Yes, I can hear you.
Okay. I'm going to start with just kind of an overall diabetes question for you before we get into the specifics of technology. What are the latest numbers in terms of individuals who either have type 1 or type 2 diabetes in the U.S. right now, and then kind of what are the people that are smarter than us that figure out how many people are going to have it in the future? What's the predictions for the future?
Yeah, well, the numbers, as most people know, I mean, they're staggering. But the number of diabetics that we have diagnosed right now in the latest data is over 29 million people diagnosed, which is a pretty significant number. But probably even bigger than that number is the estimate that about 9.7 million people are undiagnosed, so they don't even know that they're diabetics. And if for the future, and this is the ones that will most likely end up being diabetics, is the number of people who have pre-diabetes. And that number is a staggering 115.9 million people. So of these 115.9 million people, many of them will end up being diabetics unless we do something to prevent this. And so they're predicted that by and I have to look at these numbers, they predicted that the increase on the number of diabetics, it will go from 4%, and this is data from many years ago, to 7.2% by the year 2050. And out of that, they expected to increase by 271% on women and by 437% on men by the year 2050. And I know that's predictions very far forward, but these are staggering numbers. Granted that we don't expect the population to grow by that percentage.
Yeah. And that, in terms of like what that means in terms of people needing extra medical treatment, can you kind of talk about as a population what that means when you have a lot of folks who have diabetes and what kind of healthcare needs that they tend to have?
Well, yeah, the things, I mean, diabetes is a very expensive and very complicated disease. Any of us in medicine, we are constantly hearing our patients telling us that I'm diabetic and why do I take so many medications? So it's a very complex disease. It's not a disease, it's more of a syndrome. And so in the future, they estimate that the cost of diabetes in America, and the last data that I could find is from 2022, but that was $1,413 billion. So that is adding the cost of diabetic care, and also the care of the complications, the heart disease, the kidney disease, the amputations, and all the things that comes with being diabetic. So a big portion of the expense that we have in medicine goes towards taking care of the patients with diabetes. Yeah. So we, in general, we need to do a better job, not only treating diabetes, but probably even more than that is preventing diabetes, which is the biggest number, the number that I mentioned there.
Yeah.
Number of pre-diabetics is, in my opinion, and the opinion of many, is the number in which we have to make the biggest effort to find these people in pre-diabetes and try to see how many of them we can prevent them from becoming diabetics. That's a monumental task.
Yeah. Now the silver lining in this is that for folks who are diabetic, who either find ways to, if they're type 2, lose enough weight to either not get it, or if they have it, to not need aggressive medical intervention. There's people that do that, but for people who need medicine and are on medicine, whether that be some of the newer medications or insulin, if they control their diabetes, their numbers are pretty good. I mean, they tend to do all right if they control the things that diabetes can cause problems with if you have ongoing high blood sugars. So that's the good news in all this. And that's why I want to talk about the technology side of things, because at least what little I know about it, it does sound like that can be really helpful for some people. So Dr. Velasquez, first question on this: who are the folks who are the patients that are good candidates for some of this new technology that helps them manage their diabetes?
Yeah, well, in a perfect world, everybody should be a candidate for this technology. But the reality is that this technology of knowing your numbers all the time is better suited for the people who can take action on the numbers. So the people who are using insulin are the ones that when they see a high number, they can go ahead and, whether it's to get a shot of insulin or whether it's to enter a number on the pump, they can do a correction. But in reality, there's there's studies showing that by using this technology on patients, even on patients who are not on insulin, the reduction of hemoglobin A1C, depending on which publication you look, is anywhere between 1.6 to 2 point something percent change on hemoglobin A1C. And for the people who are not paying attention to this, and they think, oh, 1% change on hemoglobin A1C, it's not a 1% change on the amount of control that you get. It's a 1% change on the number. So it's bringing that 8% down to a 7%. So if you are looking at percentage of improvement, we're talking about 10 to 20% improvement on the control of the blood sugar. So unfortunately, some insurance companies don't like to cover some of these devices for patients who are not using intensive insulin therapy. And they're hanging on to a study done, it was the Accord study many, many years ago. And it showed that if you give patients the numbers without giving them the tools to do something about the numbers, they could have increased stress and anxiety. But these numbers are showing that when these people see the numbers, even if they don't have the tools to lower the blood sugar in the form of an insulin shot they can get, they change their behavior. And then they know that I ate that pizza yesterday and my blood sugar went up by 200 points. Well, I'm not going to eat that pizza anymore this way because I know what happens when I do that. So people change their behavior. So this technology can help anybody, but we're using it mainly on patients who are using intensive insulin therapy nowadays.
So insulin pumps have been out, and the sensors for the insulin pumps and those type of things have been out for, I don't know, 20 years or so. I don't know, around that time frame. What's different now about this technology, about these pumps and about these sensors than the earlier ones, Dr. Blasquez?
And just as a note here, the pumps have been in the market for over 30 years.
Okay, all right.
The initial pumps, which was, I remember seeing that in my training, the initial pumps were a big white device, and it was just a different delivery system. It was just a reservoir with a catheter going into under your skin, and then you would have to punch the numbers. So it's just a different delivery system. That's all they did for many, many years. That's all they did. And then they came with pumps that would have basal insulin, so they would be delivering some basal insulin. And that's a technology that we kept with a basal insulin, an amount of insulin the pump is trickling on you all the time.
You want to talk, what does basal mean?
Basal is the amount of insulin that you need to maintain life when you're not eating. So we humans produce about 1 unit of insulin per hour. So the insulin pumps on a normal person with normal sensitivity to insulin, they're delivering about 1 unit per hour, between 0.8 to 1 point something units per hour. And we call that basal. That's what you need to survive if you are an insulin dependent patient. So then the devices went from giving you a basal and you would put the bolus to devices that actually told you how much you should get for the bolus. So they did the calculations for you. It's called Bolus Wizard. So you would only put in there 60 carbs, and the pump would say, well, based on your history, you need to get 4 units. So that was a quantum leap a decade ago. And in the last 2-3 years, this technology has exploded. So now we have pumps that is what you could call a mechanical artificial pancreas. So now is a pump in connection with the sensor, and the sensor is telling the pump what your blood sugar is doing all the time. And the pump is actually deciding whether to give you more or less insulin. And so it has come from a delivery system to an almost independent system. And that's why it's called hybrid closed loop. It's hybrid because you still have to do some intervention. So what has made this possible nowadays, which is one of the things we want to talk about, is the availability of having sensors. People having a sensor that is telling you your blood sugar all the time, and then putting apps on the phone and being able to look at your blood sugar on the phone. And so based on that, then you can take action regardless of what system you're using. So if you want me to talk about the sensors here, we have different brand names of sensors, and they all have similar technology. Sensors, at the beginning, they would last only a few days, and now they last 7 to 10 days. They have come from a device that was probably a few inches in diameter to less than a quarter in size nowadays. You put the sensor, there's some calibration at the beginning, and it tells you your blood sugar all the time. This can be linked to your phone through different apps, depending on which sensor you're using. I'm not going to say specifics about one sensor or the other one. That I don't want to be biased against one against the other one. They're all pretty similar. They
Yeah.
all have this technology that is very reliable nowadays. And you calibrate at the beginning, and you go from there.
And those sensors, they'll also give direct feedback, not just to your phone, but to the pump. Is that right?
In the case of the pump, yeah, the sensor works directly with the pump.
Okay.
So we have, I believe we have a slide that shows, download from a typical patient with a pump. And let's see if we can get one of those on the screen. And yeah, so this here is a download from a patient with a pump. And I know the data is pretty small here, but if you look at the line on the green on the top, this is the sensor. So the sensor is telling you all the time what your blood sugar is doing.
Okay.
Now the sensor talks to the pump. And if you see those little towers at the bottom, those magenta little towers, those are insulin little boluses that the pump is giving you every 5 minutes or so. So
Okay.
when the blood sugar is going up, the pump will give you more insulin. When the blood sugar is going down, the pump will actually stop giving you insulin for a few minutes, 5, 10, 15, 30 minutes, whatever
Yeah.
time is needed.
And I'm looking at that on my screen. To me, it looks more like kind of pink purple when you say magenta, right?
Magenta, purple, pink.
Okay, just making sure that for those folks who are like me who aren't so color savvy.
Yeah, we had a discussion about that, whether that was magenta or pink, and I decided magenta is nicer.
All right.
We can go.
Yeah. Okay. So there's two. There's actually, yeah. So the green
colors.
is the sensor, and the purple is the pump, or the magenta.
At the bottom, the little towers at the bottom,
Mhm.
that is the pump. Now, the little circles that you see at the bottom, you see a number in those circles, and you see an orange square, and on top of that, you see a blue, like a
Yeah.
flag. So the orange square is and again, it's pretty small. Hopefully, you can see that. But the square is the amount of carbs the patient can put in there. I ate so many carbs. And the little drop that you see there telling you a number, that is actually the amount of insulin the pump has decided to give you based on the history of how sensitive you are to the insulin, but also based on whether your blood sugar is going up or down. So it will adjust. The pump also determines how much insulin you have on board from the last couple of hours. So if you have a lot of insulin on your system from the last couple of hours, it will give you less. And then you can see on those purple, magenta, pink, or whatever color we decide to call at the bottom, you will see pauses there. You will see times in which you don't see any towers. And that is when the pump sees that the blood sugar is going down and the pump just stops.
Mhm.
Stops and waits until the blood sugar starts going back up again. Now you also see those bars, the blue bars there, and those are on top of the blue
Mhm.
drops, if we can call them that way. And that is that bolus that is given you for that meal. On this download that we see here, for the people who are very interested in the details of this, you can see also on the third day, 1, 2, 3, the third day, you see these bags with a black square on the top saying a number.
Yeah.
And that is the patients, every so often, they have to change the sensor. And this technology, as good as it is, one of the frustrations with the patients is that this whole process of changing the sensor and adjusting and calibrating takes about 3 hours. So the sensor needs to do what they call warm up and start giving you the data,
Okay.
just and calibrate. And you do waste 3 hours of your life every 10 days or so, which is a small price to pay in the big picture of the improvement you have in your life.
Okay. During those 3 hours, does the pump keep giving you some insulin, or does it just stop, or how does
Yes,
that?
that's a very good question. So the pump goes into what is called the basal that we have programmed into the pump.
Okay.
The pump is automatic all the time, with the exception of when something happens, either the sensor is being calibrated, or for whatever reasons your sensor broke down, something happened to the sensor, you didn't get it, and then the pump goes to a basal rate that we gave to the pump. So it's like a backup plan.
Okay.
That's a fixed number. We tell the pump give 0.8 units per hour, and the pump is going back to this basal.
And once again, so is the sensor and pump telling you how many carbs to have, or is it just reacting to the carbs that you decide you're going to have?
You can go both ways. So in this new pump, they have something that is called the meal detection mode. So the pump, by an algorithm that is beyond the math that I know, determines how fast your blood sugar is going up, even when you don't put a meal there. Let's say you ate 60 carbs and you forgot to put it on your pump. So the pump will see how fast your blood sugar is going up. And the pump will decide that you probably ate something. And based on historical data from the last 6 days on the memory of the pump will calculate how much insulin you should be getting. So
Okay.
then the pump will start giving you a bolus based on what is called a meal detection. So then as your blood sugar is going up, the pump will get more and more aggressive, as you can see here. And it will keep giving you more micro boluses. And on this graph that we have here, you see that it goes from, now looks more like pink, to the blue lines. And the blue line is actually a meal detection. The pump decided, well, we need to give you more.
Okay.
Something is happening there. And once you start coming down, then goes back to this aggressive basal that it keeps going down and down. And if you go too low, like you can see on the right side of the curve, then the pump stops.
Okay.
So, in my opinion, one of the biggest advantages of these pumps, besides micromanaging your blood sugar all the time, is the fact that now people can go to bed and they can rest assured that it will be very unlikely to have an insulin reaction in which they will go too low.
Yeah.
And historically, you see patients that they say, "Oh, I have to have a snack before I go to bed,"
Because they're concerned about that. Yeah.
You don't have
Absolutely.
to do that anymore.
Yeah. What was the other slide that you had up that we had to that we put away? What were you trying to show us on that one? That one right there.
Okay.
What were you trying-
So this slide here is compiling the data from 30 days, and this is very unusual. This is a patient who's achieving 100% control. In reality, this is extremely unusual. This is one patient in my practice. I'm not going to say that most people can achieve that.
Yeah.
Most people achieve, in good control, they achieve 82 to 84% of the time in range. With that little percentage of time not in range is on the meals, in which they go and cross the line a little bit during the meal. But this is a very unique case because technically this is a patient who's still producing some insulin, and that buffers the reaction a little bit. So this gives me 30 days of data. It is very cluttered with information. I'm not going to go into the details of all this information, but you see 2 green bars at the bottom.
Yep.
Those 2 green bars tells me how is the control on this patient on the last 30 days for the A bar, and how is the blood sugar control on the previous 30 days on the B bar. And the graph that you see at the top, they compile the data from those last 30 days. And then you have the upper and lower controls, which are the 25th and 75th percentile. And then you have the 50th percentile, which is more like an orangey colored, I guess.
Okay.
And then you have the center line, which is the 50th percentile, what is the average they have.
Okay.
And when we download this data on patients, we can tell them, again, this is almost a perfect case, but we can tell them, we can tell how many times they use the bolus, how many times they enter the meals, how many times they did corrections, how many times they forgot to put the sensor and all that data. And this data, besides being available to us when we download, patients through the app on the phone, they connect the sensor to the pump through Bluetooth. They connect the pump to their phone with the same technology. And then they connect their phone to the website through the Wi-Fi at home. And they can, in their own computer, they can have access to all this data and share this data. Not only with us providers, in the case of family members, the husband or wife, in the case of pediatrics, the parents, so they can remotely monitor the blood sugar on these patients. So you can have somebody here and the partner might be in Europe on vacation or in a meeting, and they can actually see what's going on and communicate with the patient.
Okay. Yeah. Very interesting. So if I'm diabetic, please sign me up for one of these, if you would.
Yes.
What percentage of your patients have this newest technology? And and how hard is it for them to get this with insurance and those type of things, Dr. Plex?
So the percentage of type 1 patients, is less than 5%. It's a small percent of patients who need to be on a pump because they don't produce any insulin. But these are the people that, they don't get the insulin in 24, 48 hours with no care, they can be dead. So it's a lifeline for them.
Mm-hmm.
So I have converted most of my patients on the previous pumps to these newer pumps. The only ones that have not been converted to this pump is because insurance reasons. If they got a pump 2 years ago or 3 years ago, and they have their own regulations on when the insurance will cover for the new pump.
Okay.
We try to link all these patients. We tell them we want you to be linked to the computer. We want you to be linked to the system so we can help you.
Yeah.
So you can have access to information in case you get admitted to the hospital or in case you lose a pump and you are far away and they FedEx you a pump.
Okay.
They're on the pump when you get your new pump.
Yeah.
And you can share the pump, with all the providers in case you need to go somewhere else.
Yeah.
I'm
sorry for interrupting, but one other thing that just crossed my mind, you said like if there's a pump malfunction or you need a new pump, you can get it FedEx to you. How reliable are these, and how often do they, I don't know, break down or not work? And what happens in that situation?
Yeah, the pumps are very reliable. They, I can count with one hand how many of my patients had a problem in which they had to get a new pump. I believe it's been, with this new one, I believe it's only 2 patients in which they had to get a new pump. And it turned out to be not really a problem that kept the pump from functioning, but it's a safety issue with the cap on the reservoir on the pump cracking and not being tight enough to do good control.
Okay.
So it's been a couple of those. The company is very good, even on the pump, and all these patients have the access to the number. They have a 1-800 number. And when you lose a pump, one of 2 things: either you can go to a local center and you might be able to get a loaner because other places try to have a loaner if possible, or these people are on speed dial to get them. But they also FedEx you a pump. Usually overnight you get your new pump. And so then you have to go into shots for 24 hours or so.
Yeah.
But then the technology is very reliable. And also, these pumps for the patients that we think, oh, this person is not good and they're not going to do good on this pump because they're not committed
to
what it takes to do this. And I know this is one, but I can quote an example of one patient in my practice. Of course, I'm not saying names, but a patient in my practice that she has been, she has been horrible on her control because she's not eating the carbs, she's not doing anything. And I said, I have to put her on a pump. And she was reluctant. And even the people with the pumps were, well, how is this going to work when this patient doesn't put anything on the pump? So we just put her on a pump about 5 months ago.
Yeah.
She's doing excellent. She went from hemoglobin A1C on the teens. And the last hemoglobin A1C, I believe it was 7.6, which is not excellent, but it's a very good number.
Oh, that's awesome.
It was on the
teens to this. Yeah.
And the amazing part of all this is that she is not putting the carbs. She's not entering anything on the pump. The pump is on fully automatic system. I look at
it's essentially trying to be an artificial pancreas.
Correct.
Yeah.
So I look at the download on her, and there's nothing. She's not putting any information on the pump. She's just putting the pump and go, which is the way she is, which is why I wanted on this pump. And it's working great. It's working great.
Yeah, it's kind of back in the day. I remember that that was definitely one of the things. Like, well, you can't have a pump if you're not going to be really on top of things. And I'm hearing that is changing considerably based upon that story.
And now this is the opposite. If you're not getting control with multiple shots because you're not very compliant and you forget to get your shots when you eat, this pump is a better alternative. These type of pumps are a better alternative.
Yeah.
So she put in here a chart that gives you an idea of the hemoglobin A1C, because when I said that putting patients on sensors and they drop a 1% or 1.6%, depending on the data that you look at, there's one of those in PubMed from 2020 that actually the hemoglobin A1C drop in one of the groups dropped by 2.4% just by putting a sensor. So if you look at this graph here, and we can pick an easy number like hemoglobin A1C on 10, just because it's an easy number 10. And we say this person will drop 2.5%, going from 10 to 7.5%. that means that your blood sugar went down on the average from 226 to 169.
I'm even reading across at 240
Yeah.
to
So that is huge. You know,
Oh, yeah, that's a game changer for someone, because the blood sugar issue, it's just a constant affecting your body over time. It's time under tension, and if you have less tension, you're going to have more time.
Yes.
That's awesome. Well, we've just scratched the surface, I know, of this whole topic, but I thought it was what I've been reading lately. I thought it was interesting enough and enough of a change that I wanted to make sure that I got you on here so that you could talk to folks, at least to give them a taste of what's possible, particularly for those folks who are struggling to control their diabetes well. That this is something that definitely should be considered. Yeah.
On that note, just to add, because you know the number of people who need a pump is a small number. The number of people who can benefit from having a sensor by itself is a huge number. And so I'm telling people out there, you know, you can talk to your provider about getting a sensor. And if you are doing insulin and you're doing multiple shots per day of insulin, getting the sensor approved is a no-brainer. It's very simple. If you're not on any insulin, it becomes more difficult. But even if you're just doing one shot of insulin per day, a basal insulin, most companies will cover for a sensor.
Okay, so even without a pump, having a sensor allows you to look at your phone instead of having to prick your finger.
Correct, and all that data is also being stored. And when they come for a visit, we can download that data and we can say, "Oh, look at this! You have a problem with dinner." Versus could be the other way around. We can say, "Oh, you are high all night, so I need to adjust your basal insulin."
Yeah, that is a big game changer too.
Correct. So not only for the patients, they get the benefit of knowing the blood sugars, but we get the benefit of tailoring the treatment better based on information of what's really happening from day to day on these patients. Yeah. And if we can lower the hemoglobin A1C, like this study that I told you from 2020, by a 2.4% numbers on the hemoglobin A1C, just by putting them on a sensor, that is a huge improvement on care.
Absolutely.
Huge improvement.
That's just the sensor. That doesn't even include the pump?
Correct. That is just
okay. I wasn't following that. Okay.
No. That is just putting somebody on a sensor and telling them, now you take control of your blood sugar. So we give them the sensor, we give them the tools. Yeah. But you know, nobody likes bad grades. So when you look at that number and the number is not good, you know, most likely you're going to take some action.
Yeah. Well, that's a heck of a lot easier to look at a phone than to prick your finger and take all, you know, you can be anywhere you want to be and look at your phone instead of your finger prick. You got to have the equipment and all that kind of stuff. So I get it.
And it changes behavior. I cannot tell you how many times I use a sensor and people come back and they tell me, I did not know that pizza could raise my blood sugar that much. And I don't tell them that, you know, the sensor told them that.
Yeah. Yeah, absolutely.
And then they change the behavior.
Hey, this has been great. As always, thanks, Dr. Blazquez, for taking the time and explaining your expertise on diabetes. And for those of you who are watching this, please feel free to share this with those around you, because I'm sure you have those around you who are diabetic. And this is great information. So thank you so much for taking the time to be with us.
My pleasure. Thank you for having me.
Okay. So yeah, please reach out to those around you and share this with others so they get a sense of what's a possibility for those of folks who are diabetic. And now I'm wondering if Rebecca, yes, I thought she might. So I want to congratulate our employee of the month for October, Tara Jackley, Central Scheduling Clerk and Patient Access. And November employee of the month, Heather South, who's the General Secretary and Laboratory at the clinic. And then, and yes, Daisy Award winner, congratulations to Angie Sullivan, who is an RN on the medical floor. And Sunshine Award winner, Blanca Ramirez, who's a CNA in our critical care unit. Yeah, blood drive. There's the date, there's the time, there's the number. Please, if you're so inclined, reach out and give. And as Sherry mentioned at the beginning of this episode, looking forward to talking with Dr. Tran and Dr. Jones in January about all things menopause, because they have started they both are having menopause clinics right now, and I'm hearing really good things and really good feedback about those clinics. So more to come on the time and date for that. And yes, to you and to yours, I hope you all have a very happy holiday season, and I will see you all back, as will Sherry. We'll see you back in the new year. Until then, thanks for watching.